can the diaphragm tell us about the clinical use of pressure support or any other modes of mechanical ventilation? Dr. Stefano Mutini works in the Medical Surgical Intensive Care Department of Vimercate, Italy, together with 8 other physicians. They met the challenge of treating over 390 patients during 2014 in their 8-bed ICU. In the past, Dr. Mutini and colleagues were looking to work more efficiently with better treatment quality.
Our aim in the ICU is to gain time restoring altered parameters using most of the time a symptomatic therapy in addition to causal therapy in order to help the patient. Those parameters are provided by vital signs, such as physical examination. For the hemodynamic vital signs are pressure, like central venous pressure, invasive blood pressure, pulmonary artery pressure. For the kidney function, a vital sign is diuresis. In respiratory terms, we can consider 2 vital signs only: respiratory rate, tidal volumes, and oxygenation. Symptomatic therapy carries side effects that should be minimized. We know that ventilator therapy may initiate or exacerbate lung injury. Protective ventilation has become standard of care to prevent ventilator-associated lung injury. More recently, another side effect involving diaphragmatic weakness has been investigated. It is known as ventilator-induced diaphragmatic dysfunction. We need more vital signs from the respiratory system, and the scientific research in recent years is focusing, among others, on the diaphragm function. It seems important to allow as much diaphragmatic activity as possible in order to minimize the risk of VIDD and to determine how to promote the diaphragmatic effort during mechanical ventilation.
The process from controlled to assisted ventilation should be synchrony between the patient's own respiratory effort from the breathing center and ventilator delivery of inspiratory flow. The many advantages of synchrony, according to Dr. Mutini, are normalized work of breathing, avoidance of diaphragm atrophy, decreased need for sedation, patient comfort, improved patient-ventilator interaction, early weaning, and improved hemodynamics.
Traditionally, in pressure superventilation, a low respiratory rate in response to increased pressure support level was seen as an indication of improvement. But how can we see if this is true? As well as if tidal volumes of 6-8 ml per kilo predicted body weight are good indicators of ventilatory assistance level? Do we have more vital signs that can be useful to explore the adequacy of ventilatory assistance during pressure superventilation? For the respiratory system, we have a few respiratory vital signs, such as respiratory rate, tidal volume, and SpO2. We also have other valuable information such as blood gas analysis, imaging, and all parameters derived from mechanical respiratory maneuvers like occlusion maneuvers, pressure volume curves, weaning index. But these are not true respiratory vital signs.
So what can the diaphragm tell us about clinical use of pressure support? In Dr. Mutini's experience, the electrical activity of the diaphragm, or EDI in pressure support, may inform us that increasing levels of pressure support may depress the electrical activity of the diaphragm, or may illustrate trigger delay and auto-trigger in pressure support, or may reveal ineffective patient efforts to breathe.
In terms of timing asynchrony in supported ventilation, the timing asynchrony, that is discrepancy between the timing of the neural respiratory cycle of the patient and that of the ventilator, such as auto-triggering and ineffective force, and the flow asynchrony, that is discrepancy between the amplitude of the neural respiratory output and the level of assist from the ventilator, they both result in lack of proportionality, which is very hard to see without EDI. Asynchrony means increased need for sedation, worsening of gas exchange, and prolonged ventilation. It can lead to higher morbidity and mortality because of prolonged ICU stay.
According to Dr. Mutini, the EDI curve reveals common pitfalls with pressure support ventilation. A small patient effort only to trigger the ventilator may result in flow assist asynchrony, where the patient is not in control of their breathing pattern. Timing asynchrony in pressure support between patient and ventilator is greater at higher levels of assistance, leading to reduced respiratory drive and overinflation.
If you want to know and use EDI, you need to know the physiological basis. All muscles generate electrical activity to excite muscle contraction, including diaphragm and respiratory muscles. Electrical excitation is controlled by nerve stimulus and controlled in magnitude by adjusting stimulation frequency or nerve fiber recruitment.
EDI is related to the phrenic nerve activity, which is present in healthy subjects as well as patients with acute respiratory failure and chronic respiratory insufficiency. In the experience of Dr. Mutini, the EDI is a vital sign. The electrical activity of the diaphragm is related to global inspiratory efforts and can indicate anatomical issues such as diaphragmatic hernia, central causes such as no respiratory drive due to sedation, hyperventilation, or brain injury, and peripheral causes such as diseases with phrenic nerve or neuromuscular junction involvement.
If the patient did have any central nervous or peripheral dysfunction that could influence EDI generation or its detection, the EDI value variation tells us something about the patient condition. Increased EDI may be related to respiratory load or exercise. It is related to the increased respiratory drive. Reduced EDI values may be related to increasing unloading with mechanical ventilation or decreased central respiratory drive due to sedation. In monitoring, we find the EDI useful in different ventilation modes, so we can see the adequacy of ventilation support, patient ventilator synchrony, or evolution of neuromuscular deficits and respiratory failure. We can even monitor the EDI of spontaneously breathing patients when they came off of the ventilator. In ventilation therapy, we find the EDI useful in applying the mode Neurally Adjusted Ventilatory Assist, or NAVA.
Dr. Mutini and his team will now demonstrate the application of EDI on an ICU patient. They follow a simple standard procedure for insertion of the EDI catheter. Select EDI catheter size for the patient. You need to know the patient's height. A table provides more details. Make a NEX measurement from the bridge of the nose to the earlobe and then to the xiphoid process. This is the NEX measurement. Calculation of insertion distance for the EDI catheter depends on the catheter size and if nasal or oral insertion. Next, dip the EDI catheter in water for a few seconds and insert up to the calculated insertion distance. It is placed in the esophagus just like a normal feeding tube. If you intend to also use the EDI catheter as a gastric feeding tube, remember to follow your hospital routines for gastric tube placement. Verify the EDI catheter position by analyzing the ECG waveforms. Ideally, P and QRS waves are present in the top ECG curves. The P waves gradually decrease and disappear in the lower ECG curves, where QRS amplitude also decreases. If the bottom leads are highlighted, Insert the EDI catheter further until the pink highlight appears in the center. If the top leads are highlighted, retract the EDI catheter slightly until the pink highlight appears in the center. The pink indication can only be used if there is a stable EDI signal. If the EDI signal is very low or absent, there will be no pink highlights. An absent or low EDI signal may be due to hyperventilation, sedation, muscle relaxants, or neural disorders. If the respiratory drive becomes inhibited, the EDI catheter can stay in place until the EDI signal is reestablished.
Our routine is to perform the next measurement first, and then we look carefully at the esophageal ECG waveform. Finally, we look at the EDI curve and perform an expiratory pause to note if the EDI signal curve coincides with the pressure curve deflection during airway occlusion. Now, we are ready to illustrate the value of the electrical activity of the diaphragm for this patient. Okay, this patient, she is a patient admitted more than 2 months ago in the intensive care unit because of septic shock due to liver abscess and a secondary acute respiratory distress syndrome. Now the patient has she's become better from septic shock. She remains with respiratory failure. She is now on assisted ventilation and pressure support. And we can see the parameters of pressure support ventilation. As now the patient is on 5 centimeters waters of PEEP, a low FiO2, and the pressure support that is more 14 centimeters water above PEEP. And if you look at the parameters like respiratory rate and tidal volume, you can see that the patient she's receiving an adequate amount of ventilation because the respiratory rate is below 20 and the tidal volume is 6.5 milliliter per kilo of predicted body weight. So I can say that the patient looks adequately ventilated with these parameters of assisted ventilation. Even the blood gas analysis is okay with this ventilatory setting. But the true problem is that what we can say about diaphragm activity on this ventilatory setting without EDI. I can talk about adequacy of ventilation because of respiratory rate and tidal volume and because I can't see any ineffective efforts or any major asynchrony on the flow curve. But I think I need something more, and something more is EDI signal. So let's see what's happened when we display an EDI signal on the ventilator through a EDI catheter. As you can see, we don't have any EDI activity displayed on the ventilator, but we have some degree of flow asynchrony. The flow asynchrony means lack of proportionality between patient needings and ventilator assistance. You don't have almost nothing performed by the diaphragm, but you have a plenty activity of ventilator. So let's try to decrease the pressure support and see if we can see something more coming from the diaphragm. We'll go down in 3 centimeter water steps and we will look at the EDI signal. As you can see, there is an effective effort. Something more happens. I can see something coming from the diaphragm. It's still very low in amplitude. So I think I can go down further. 3 centimeters water step. Let's wait a few seconds. It's very important not to resize the EDI scale because you can't appreciate the variation. As you can see, the diaphragm is starting to work. We don't have any ineffective force on the flow curve, but even on the diaphragm EDI curve. The diaphragm activity is still low, so maybe I can go down a little bit with pressure super. Remember, we're starting from 15. We have lost 7 centimeter waters of pressure super above people. Let's go down to 5, and let's see what's happened. We can see that the EDI peak is increasing. We lack some tidal volume, but we don't have high respiratory rate now. We have to wait that the patient, the central respiratory drive of the patient can understand that miss some support from ventilation and generate a more intense signal for the diaphragm. Let's see if it will happen in the next few minutes. Okay, at the moment we have a good diaphragmatic activity. We have a still low tidal volume that maybe is not enough, but we will see on the blood gas analysis. We don't have high respiratory rate. If the patient will not increase the EDI peak to match, I guess this set is a good set of ventilation for this patient. We will check the blood gas analysis in a few minutes. We will check the EDI activity in a few minutes. But if the EDI peak is stable, I can say that the patient is properly working with the diaphragm, and the patient had lost almost 10 centimeter waters of pressure super. That means that the patient was really over-assisted before, even if respiratory rate and tidal volume tell us that the level of assistance was adequate. Let's see what's happened if you want to trust the usual vital sign that we use in assisted ventilation, like respiratory rate and tidal volume. As you can see, with this pressure super setting, we have a good and pretty evident diaphragmatic activity, but we have a little bit high respiratory rate and the tidal volume that is quite low. So usually what we have to do if we don't have EDI signal, we want to increase pressure super because we want to lower respiratory rate and to have a higher tidal volume. So we go up in 3 centimeters water steps. Remember that EDI is more or less 10 microvolts now, and let's see what's happened. The central respiratory drive response is very fast usually, so let's see in a few seconds what's happened. Nothing special, the respiratory rate is still high. Let's go up again. 3 centimeters water steps. Let's give the time to the patient to know that we are assisting her. As you can see, the diaphragm activity is less evident. We have 6 microvolts of EDI peak, a slower and not so evident decrease in respiratory rate, and not a big augmentation of tidal volume. So I want to have a respiratory rate below 13, so 3 centimeter waters increase. an effective effort, a SIG, and then you can see almost complete diaphragm activity suppression. The EDI peak go down. You have a major asynchrony. This one is a timing asynchrony. This one is a timing asynchrony. You can see there on the flow curve. This one is timing asynchrony again. So, okay, this is the situation where we have a normal respiratory rate, a pretty normal tidal volume, above 6 ml per kilo, but no diaphragm activity, not at all. So this is a clear example of over-assistance during pressure superventilation if you targeting just respiratory rate and tidal volume and maybe SpO2. Okay, now we have back to 5 centimeter water of pressure support, and we can see that we have a good diaphragmatic activity, and we have a good tidal volume, a slightly higher respiratory rate, but this is the true respiratory rate of the patient, the neural respiratory rate from the patient. It is not an example of over-assistance, but is an example of adequate assistance in pressure support, EDI guided. Okay, let's talk about synchrony. We can have two different asynchrony types. The one is a timing asynchrony and one is flow assist asynchrony. The time asynchrony is it happens when the ventilators overcome the neuroventilatory inspiratory time of the patient. And the flow asynchrony is something like a lack of proportionality in the adequacy of assistance. Now we can try to record if with high pressure support level we can see some asynchrony with this patient. Let's wait a second and then let's look at the EDI signal. And let's see if we can see something on the EDI curve. Okay, recording. Of course, asynchrony is much more evident with higher level of pressure support. And asynchrony means morbidity increase, long stay on ventilator, long stay in ICU, a huge risk of ventilator-associated pneumonia, so we have to avoid asynchrony in the ventilatory assistance of our patient. Example of flow assist asynchrony, low EDI but high pressure support act delivered, and example of timing asynchrony. The starting of the ventilator is not the start of neural inspiration by the patient, and the cycling of ventilator is good, but the triggering is not good enough. And then an example of auto-triggering, no trigger from the patient, but trigger from the ventilator. And this is another one. No trigger from the patient, trigger from the ventilator, auto-triggering. This one is an example of a small diaphragm activity, but a timing asynchrony again. Auto-triggering again. Flow assist asynchrony. Small, not a huge delay in opening the valve, but small effort from the diaphragm and triggering the ventilator. And the same there, no EDI activity but trigger from ventilator. That is called auto-triggering, usually is due to the high trigger sensitivity, but here you can see that the trigger sensitivity is pretty normal and the flow trigger is not too low, so the auto-triggering is really caused by the high pressure support level and the EDI suppression. That means that is a true asynchrony. Both flow and time asynchrony are evident with high pressure support levels. Let's go down and let's see. Again, that the diaphragm activity will increase is pretty immediate. 5, 7, 12, okay. And here we don't have any timing asynchrony, even if we are in pressure support, but more important, because maybe in this case the ventilator trigger anticipated the inspiratory neural time of the patient, but most important, we don't have any flow assist asynchrony. That means that lowering pressure support following EDI values give us the chance to give a adequate pressure support level assistance.
In their earliest experience of EDI-guided pressure support ventilation, Dr. Mutini and colleagues studied 10 acute respiratory failure patients ventilated over 96 hours with inspiratory pressure support titrated to obtain tidal volumes of 6 to 8 milliliters per kilogram predicted body weight and active inspiration. They compared the clinical pressure support setting with EDI-guided pressure support. Pressure support clinical levels were set according to the study by Tilla and colleagues in 2008. At the positioning, EDI peak value was always below 10 microvolts, with mean 5 microvolts. Respiratory rate was below 25 breaths per minute. Mean clinical pressure support was 12 centimeters of water. Decreasing the pressure support level with the aim to obtain a good and evident EDI signal, they discovered that pressure support levels were decreased by a mean value of 5 centimeters of water, with minor changes in tidal volume and respiratory rate.
Our need to improve assisted ventilation, avoiding over-assistance and major asynchrony, and the need of winning parameters became clear to us after experiencing EDI-guided pressure support. During the past 7 years, we have routinely treated over 400 patients in our ICU with EDI-guided pressure support and NAVA in acute respiratory failure patient as well as COPD patient, in invasive ventilation and also non-invasive ventilation. We also use EDI to monitor the patients when they are disconnected from the ventilator. We feel that EDI is easy to implement and simple to use. We think that over-assistance and asynchrony with pressure support ventilation are very frequent in the global intensive care community and leads to a greater morbidity. EDI is a true vital sign coming from our patient and give us very important information about patient-ventilator interaction. If you understand EDI, the ventilation mode NAVA is easy to use. Just as ECG became a vital sign of cardiology, let's try to use EDI as a respiratory vital sign for monitoring the adequacy of ventilatory support.
To find out more about ventilator-induced diaphragmatic dysfunction or EDI monitoring in NAVA, please refer to the selected list of publications or go to the criticalcarenews.com website.